Today we are going to be talking about neurocognitive and neurodegenerative disorders. First, we're going to talk about delirium. This is a temporary mental disturbance that can decline rapidly or gradually. This is a reversible mental disturbance that is usually characterized by disorganized thinking or difficulty staying focused. If a new onset of confusion is happening, the first thing we need to rule out is delirium, and if there is an underlying issue causing the delirium. This is usually seen in elderly with an illness. Underlying causes would be your infection, drug reaction, substance intoxications or withdrawals, electrolyte imbalances, head trauma, and sleep deprivation. Dementia is significantly impaired intellectual functioning. This is cognitive impairment characterized by gradual, progressive onset. This is impaired normal activities and relationships. They have impaired problem solving and emotional control, personality changes, and behavioral problems. This is irreversible. This dementia is not a normal part of aging. And dementia is not a disease itself. This is a symptom of diseases. There are many different diseases that can cause dementia. We're going to talk about Huntington's, Parkinson's, and Alzheimer's in just a little bit. They can also have vascular dementia, which is usually related to multiple mini strokes. They can have chronic alcoholism, medications, and head injuries. All these things change the patient's mental status, leading to dementia. Some studies say that higher education, higher socioeconomic status, and engaging in simulating intellectual activities can actually decrease the chance of developing dementia. Some signs and symptoms of dementia are recent memory. So they're gonna ask, they're not gonna remember if they had eaten breakfast that morning. They won't remember a phone call that just happened a few hours ago. They can have remote memory affected, which this will be later, but they will forget how to perform simple tasks such as making a phone call. Wandering, aphasia, behavioral problems. They can become total dependents and they can start wondering. They will ask same questions repeatedly. They can get lost in familiar places and they become disoriented to time. Diagnosing can be determined by their neuropsychological testing. This will determine the degree of damage or the degree of change. They can also perform a depression test, medication review, because we want to make sure are there any medications contributing to this mental change. They can also complete diagnostic tests to see if there's any underlying cause. Main thing, we want to make sure that this is dementia and not delirium, because if it's delirium, we need to fix the underlying problem. Some therapeutic interventions would be some medications can delay the progression, which is that cholinesterase inhibitor such as Aricept, and NMDA agonists such as Namenda. And at this point, we need to make sure that we're talking about end-of-life decisions early on so that we know what the patient wishes their end of life to look like. Some things that nurses are going to look for is risk for injury. This is especially with wandering. We want to make sure we're making no rugs in the house, making sure they're not at risk for falling. Imbalanced nutrition. We have to make sure they are remembering to eat. They can have chronic confusion. And we also want to make sure we're paying attention to the caregiver, as they can become strained. And a lot of the caregivers are not going to want to admit that they need help, so it's most definitely the nurse's role to make sure that they know this is a very stressful and straining role, and to help them find the help they need for relieving them for any kind of care. Next, we're going to talk about Alzheimer's disease. This is a progressive degenerative disease. So if you look at the picture, you can see a normal neuron versus the Alzheimer's, what those neurons look like. They can have an early onset of Alzheimer's, which happens between 30 and 60 and is usually an inherited mutated gene, or they can have a late onset after the age of 60, which is more common. The cause is unclear, but they could be linked to genetic, environmental, or lifestyle factors. With Alzheimer's disease, if you have a first-degree relative that has had it, it nearly doubles your risk. It also doubles every 5 years a person lives past 65 years of age. With this, there are two different things. You have neurofibrillary tangles, and this is caused by a protein that causes the neurons' microtubules to clump together. The microtubules are structures responsible for transporting nutrients from the cell body to the axon. So if you look at your first picture of the neuron versus the second, you can see the difference of how those neurons look. The next is your amyloid plaques. Beta amyloid is a starchy protein that injures the neuron that produce acetylcholine. An acetylcholine is a neurotransmitter that is critical for memory and cognition. As beta amyloid accumulates, the particles stick together to form that amyloid plaques, as you can see in the second picture. So you're going to see those neurofibrillary tangles and the myeloid plaques with the Alzheimer's disease. Some research say that it is more common in women. And the chromosomes mentioned that are usually associated are number 1, 14, 19, and 21. And remember, 21 was also associated with Down syndrome. Here you can see the difference in a normal brain versus an Alzheimer's brain. There is a decrease in the hippocampus, which results in short-term memory loss. And you can also see that cerebral cortex, which is the surface of the cerebrum, and the cerebrum consists of all 4 lobes. So all 4 lobes are shrinking. This usually doesn't touch the basal ganglia, brainstem, or the cerebellum, so they still have the urge to survive. So what we're talking about is they may express they are hungry, or they have the urge to eat, but they no longer know how to meet that need. There are different signs and symptoms based on the stage that they are in with the Alzheimer's disease. Alzheimer's was covered in Psych, so I have a handout that talks about the different stages, warning signs, and suggestions for families caring with a person with Alzheimer's. Big thing here are the 3 different stages. In stage 1, you're going to notice an increase in forgetfulness. In stage 2, they're going to have progressive memory loss, irritability, especially when they're asked to complete a task that they know they should be able to do, but they can't remember how to do it. They could have depression, aphasia, sleep disruption, hallucinations. They will begin wandering at night. And in stage 3, this is when they have the inability to recognize significant others. They usually have bowel and bladder loss of control. They become completely dependent on others. And usually this is death will occur, but normally this is related to complications of immobility. There are some different diagnostic tests that can be done to determine Alzheimer's disease. However, the only absolute method of determining Alzheimer's is by completing an autopsy. Some therapeutic interventions for Alzheimer's would be the cholinesterase inhibitors, such as the Aricept we mentioned earlier, the NMDA agonist, which is your Namenda. You can also look at taking antidepressants, antipsychotics, or anti-anxiety to help with this. However, there is no cure, so most of your medications are going to just slow down the progression of the disease. Next, we are going to talk about Parkinson's disease. Parkinson's disease is a chronic degenerative movement disorder that arises in the basal ganglia. So, look back from the picture of the brain and the function chart from day 1 to see where the basal ganglia is and what the function is. This is a picture of Papa and Grandmommy. Grandmommy is the one that lives with us. This is Papa before he passed away. As you can tell in the picture, he is supposed to be smiling. So as we talk about Parkinson's, think of this picture and the signs and symptoms that we're going to talk about. Parkinson's disease is a destruction of the substantia nigra. This is a group of cells in the basal ganglia. And this is related to a decreased dopamine production. So remember back to our day 1, we talked about dopamine and acetylcholine. So remember, if we have a decreased amount of dopamine, our body is going to act like we have an excess of acetylcholine. There is a impairment of the semi-automatic movements, which is that posture, blinking, walking, chewing. Now, remember, inhibitory decreases while excitatory increases. So remember, our dopamine is an inhibitory while our acetylcholine increases, or it's an incitatory. So the substantia nigra is responsible for the production of dopamine, and dopamine makes the transmission of impulses from one neuron to another easier, and is a neurotransmitter inhibitory. So dopamine plays a significant role in the movement and control of motor function and learning new motor skills. Dopamine and acetylcholine are usually balanced, but with Parkinson's, dopamine is decreased, but the acetylcholine stays the same. And since the acetylcholine stays the same, the acetylcholine it seems like it's being elevated. So remember, the acetylcholine is excitatory neurotransmitter. This leads to more neurons firing than usual. So some signs and symptoms are you're going to see muscular rigidity, bradykinesia, which is slow movement, changes in posture. They will have a stooped posture, as you see in the picture of Papa. They can have pin rolling tremors. It lessens or disappears with movement. It gets worse when they are resting or trying to hold things still. These usually start in the hands. They can also have difficulty initiating movements. And you will also notice a shuffling with short steps. This is usually gradual, and as a large amount of dopamine is non-functional before symptoms actually begin. So this is a gradual onset. The difficulty initiating movement, which would be your walking, trying to stand, starting to dress themselves. This is usually related to the muscle stiffness. Once the patient is going, they also will have difficulty stopping. So here are just some more signs and symptoms of Parkinson's. Their normal blinking response can be diminished. They can have difficulty with fine motor responses. Their handwriting deteriorates. They can have a mask-like facial expression because they lose their muscle control of the face. They can have drooling and dysphagia. And some late symptoms would lead to dementia. Diagnostics, they're going to look at the patient's history, physical examination, and an MRI to rule out other problems. There is no specific test used to diagnose Parkinson's disease. Some therapeutic interventions would be your anticholinergic agents, such as the Airtane, dopamine agonists, such as Sinemet and Requip, the monoamine oxide B inhibitors, the COMT inhibitors. They can do deep brain stimulation, which is kind of like a pacemaker that they have to make, but they have to make holes in this school. So it kind of works as still like an electrical activity. These only help the symptoms, as there is no cure. Some nursing diagnosis would be impaired physical mobility, self-care deficit, and risk for injury. With Parkinson's, our main focus is on safety. The last disorder that we're going to talk about is Huntington's disease. This is a genetic, autosomal dominant, which means it is an inherited condition, meaning that the child has a 50% chance of getting it. It is a degeneration of parts of the brain. So this is a progressive, hereditary, degenerative, non-curable neurological disorder. In the 17th century, people were accused and executed because they thought that people with Huntington's disease was actually participating in witchcraft. With Huntington's, the signs and symptoms usually begin middle age, around their 40s. They can have dementia, personality changes, inappropriate behavior, paranoia, or violence. They can have involuntary, irregular, jerky movements, dysphagia, which happens toward the middle of the disease, with depression, and a lot of the depression will lead to suicide. Death is usually from respiratory failure, from aspiration. Movements usually start in the arms, face, neck, and then progressively involve the rest of the body. Our main goal here is to prevent aspiration. We can do this by having the patient put their chin to chest when swallowing, making sure they're sitting in the upright position when eating, thickening liquids if needed, and providing soft foods. These patients need to discuss the end-of-life decisions early on in the disease. Video for you in Blackboard. I've posted a video for you in Blackboard of this mother Huntington's disease, where you can see those motions of what we're talking about with patients with Huntington's disease. With diagnostics, you're going to look at family history, as it is a genetic disorder. You can look for MRIs and CTs. They can also do genetic testing to determine if they have the gene for Huntington's disease. Some medications, they can be on antipsychotics, antidepressants, and anti-chorea agents. This is treating involuntary movements and behavioral outbursts. Remember, involuntary movements of extremities can happen at any time. We need to make sure we are not mistaking this as an attempt to harm their caregivers. Women will need to be counseled before a pregnancy because it is an inherited disease. So if a woman has this gene, there's a 50% chance that her child will develop Huntington's disease.